Sorry, I'm here. Is everybody here? I just didn't want to try to Zoom from school, and I figured, so surgery was going, I got relieved and I took off. So, okay. Let me take my coat off here. Hold on. um, okay. Oh, this is recording. That's fabulous. Okay. All right. Are there any questions? Okay. Sorry, my dogs are fighting in the background, so hopefully it's not too distracting. Okay. Did I hit record? Okay. So when we were talking about the stages in plane, stage 3, plane 2, the main thing to know about this stage and this plane, remember stage 3 has 4 planes, and plane 1 was light anesthesia. This is called surgical anesthetic plane. It's basically like they should be adequate for surgery. And what you start to see is that the heart rate should start to normalize. Respiration should start to normalize. It could start to get shallow because anesthesia, they're becoming respiratory depressed, cardiovascular depression. And you should start to feel, they should be more relaxed. You don't want to see, if you pinch their toe, you don't want to pull their leg. And their eyes should rotate ventral and medial, almost like they're looking at their nose. And that's, so we have good eye position. And the thing to understand about anesthesia and to remember, anesthesia depresses cardiorespiratory function by nature, and CNS depression. That's what anesthesia does. So we are just making sure that these values aren't getting too depressed or into an abnormal value. So if your heart rate comes down and respiration comes down, I anticipate that. I anticipate a lack of jaw tone. There shouldn't be swallowing. There shouldn't be a pedal reflex. And I also don't want to see them blinking. If they can detect that, then they're going to feel the surgery. And so, and then the thing to also understand, and I kind of experienced this today helping in surgery, we had a cat spay, and when we got into surgery, she started to pull her legs a little bit. So she got a little light. We turned up her anesthetic some, and then her heart rate was coming down, respiration. Now, Dr. Ritz cut through the skin. She didn't react. We had the cat at 1.25% ISO. So that's a nice low amount. She had good blood pressure, but respiration was lower than the prep room, heart rate lower than the prep room. But then I was getting ready to leave, and she was getting to the point where she was breaking the broad ligament and getting ready to tie off the ovarian artery. And then also I could hear the heart rate coming up and respiration was increasing. So even when you're in a good stage 3 plane 2, sometimes there's parts of the procedure, like when she first pops the testicle out and goes to break the tunic, a lot of times dogs will, they start to huff and puff, heart rate comes up. I just told my anesthetist, I said, turn up the gas a little, give her a couple breaths. But then what happens when the doctor stops doing that, when they take off the clamp or they stop cutting the tunic, a lot of times those values are going to come down. So as an anesthetist, this is a real world tip, you don't want to crank that animal up too high because potentially they could get a little too deep, because once the stimulus is gone, they kind of come back to where they were. So, a good surgical, now the heart rate was coming up and respiration was coming up, but the patient was not blinking and the patient was not moving. So it wasn't to the point where, because I've had some surgical stimulation where the animal potentially starts to move and maybe they start to like swallow, then they're way too light. But sometimes you'll get a little bump in blood pressure and heart rate with some stimulation. Now, PLRs, I do not check routinely during anesthesia unless I'm really worried about a patient's brain function, head trauma, or if I'm really worried that we're getting close to cardiac arrest. But in stage 3 plane 2, they should still have a little bit of pupil response, but it should be slow. You don't want to see a rapid movement of the pupil when you shine light on the eye, because then that's a pretty brisk reflex. So I should, you might see a little bit of pupil um, constriction, and you may see um, that their eyes are somewhat dilated. Now, if you turn up the patient and you leave them up, you can get into stage 3, plane 3, which is considered deep anesthesia, which is probably excessive. A patient will survive in stage 3, plane 3. But what we're starting to see, it's a little too much anesthesia. Now remember, you are supporting them physiologically. We don't want to alter blood pressure and heart rate where it's going to affect the animal later. So what you start to see is your heart rate's continuing to go down. So if you say we turned up the patient today, it was only at 125. Say she put it up to 2 and she left it at 2%. Because I will tell you, I hear time and time again from students that have been out on externships or they work somewhere, and they're like, they just put the cat on 3 and leave them on 3%. Well, I get a lot of animals down to 1%. I mean, if you have a good pre-med and we have a relaxed patient, a lot of them aren't going to need 3%, and they're probably hovering in these deeper anesthetic planes. So low heart rate, low respiration, decreased tidal volume. Now, if you remember what tidal volume is, that's the amount of air the animal breathes in one breath. So anytime an animal is respiratory depressed, you're going to have a decrease in tidal volume. But what happens is when they breathe, what do they get rid of when they breathe? What do they get rid of when they exhale?
Carbon dioxide.
Carbon dioxide. So the more respiratory depressed they are, and they're not breathing as often or as deep, you're going to potentially see an elevation in your carbon dioxide. Now, we have an end-tidal CO2 monitor at school, and some clinics have it, some do not. So you may not see a low CO2, but or a high CO2, but the less they breathe, the less deep they breathe, typically that CO2 starts to come up. And when it gets too high, you get what's called respiratory acidosis. And that means they have too much CO2. And if you remember, I'm doing the respiratory lecture for anatomy right now, so it's kind of fresh in my head. I said in anatomy, when your CO2 goes up, your pH comes down. And whenever your pH goes below 7.4, that's acidosis. Now, this is respiratory in nature, but you don't want to set up a metabolic acidosis because that affects cellular function. So do you see where I'm getting at? If we get them too depressed, it's going to affect all these other things. So sometimes when they are in this stage, they have like their pulse is decreased, like the pulse strength. Their CRT might become extended, which is affecting perfusion. The reason you check CRT and the reason you want it below 2 seconds is then that's typically adequate blood flow to the tissues. When you start to get to 2 seconds and over 2 seconds, that's an indicator that blood's not making it to the tissues. And that is perfusion. That's another thing that we don't want to alter. Oxygenated blood has to get to all the tissues. That's our goal. Probably a lack of PLR. And the big thing that tells me my patient's getting deep is these central eyeballs. The eyes start to rotate. Remember I said there's only 2 times a patient is looking at you. They're either awake or getting ready to check out. So when you have central eye position, and then, so if I see my eyeballs looking at me, and I see my heart rate's going down and my respiration's going down and their pulses are getting weaker, that's pointing me, that's a breadcrumb, that's a clue. Everything's telling me that it's going in a downward slope. The patient is maybe too deep, then I maybe need to turn down. Because when you turn down the anesthetic, your goal is to get them into stage 3, plane 2. When an animal goes to sleep, they go from stage 1, past stage 2 really quickly, stay in stage 3, and then we maintain. If they start to hover, we want to wake them up. Now, we don't want to get them all the way awake. So this is what I mean by hovering. And that's why you watch your trends. And this is what monitoring is about. No reflexes, and they feel very relaxed, flaccid muscles. And then if you keep them up, if we don't make any changes, they're going to eventually move into stage 3, plane 4, which is early overdose. We're heading into anesthetic overdose. Now, what's going to happen when the animal is severely respiratory depressed? The body can trigger the diaphragm to try and use it more on your abdominal muscles. And sometimes you're going to see more abdominal breathing. And that's an indicator that maybe they're too deep when you have more abdominal movement. Dilated pupils, no reflexes, no blink, loose, loose, loose jaw tone, like it feels very eerily loose. And then obviously your CRT is going to get worse because your blood pressure is going, so your heart rate's going down, your respiration is going down. And one piece of advice, and I feel like, especially because I've been with anesthetists recently in surgery, and eventually you guys are going to be there. If you are worried about your patient, I had whatever that collie mix is that's in the kennel now. She's kind of, or he's kind of skinny. He had a dental today. Looks like a collie. He's got black and tan. I'm trying to think. I'm really bad with their names.
I think it's Blitz.
Maybe it's
Yeah,
Blitz.
it's Blitz.
Yes, it's Blitz. I
Looks
was on the
like
tip of my tongue. I couldn't think of it. It's
It
Blitz.
doesn't look like a
Yeah.
full collie. It doesn't have like the full collie, but it's got like the very long snout. Looks collie-ish, and collies are one of my dogs. Now I helped with his neuter last week or something, and I said, guys, this is a collie mix, and I always go low on my doses. That dog was bottomed out, and then when we went in for the neuter, right after she started doing the surgery, I noticed he was pale, and then the heart rate plummeted to like the 40s, and blood pressure was definitely going down. And I was like, you know what? I was this close to completely turning the dog off of anesthesia. I gave atropine, and I said, get that dog on 0.5%. And I started squeezing in fluids, and his heart rate came up and pressure came up, and he started breathing a little. So then I turned up his anesthetic. But in that brief moment, I was concerned he got excessively deep. So I was like, I'm going to turn off the anesthetic. What's the worst thing he's going to do? He might start moving. He might start waking up. But most DVMs are going to tell you, I'd rather have a light patient than a dead patient. If I'm going to err, I can get the dog back asleep. But in that situation, I was kind of abrupt, and I just was like, get that vaporizer down, give me some atropine. And I think he had some vagal stimulation, and he was down for a while. He came back up and he did fine. So, oh wait, you have a question. When you do anesthesia, it is mostly experienced people. Kayla, that's a good question. It is going to come with experience. And every time I did anesthesia, especially when I was starting out, I learned something. You definitely take, oh, I'm not going to do that next time. Or, oh, I saw Miss Landeros, she turned him down. Or, oh, Dr. Ritz told me to do this. You know, it will build. And the thing is, you just have to trust your gut. Now, it's going to take you time to develop a gut, if that makes sense. You know, you're not going to go into surgery day one. I did make mistakes, and sometimes you misinterpret things, and I learned by every single one of these experiences. But as long as you kind of have a plan in your head, like I'm giving you guys parameters, and I'm telling you, when you see this, this is what this probably means, you do this. So yeah. And you know, like the students that I was helping with anesthesia, these days I've gone into surgery, you know, they're all stressed, they've been flustered, and they've made some mistakes. But I'm like, you guys are learning. I don't expect you to walk in and be like, I'm going to turn them down, go get me atropine, let's give some fluids. Like, that takes experience. But they all had their parameters with them. They had their little cheat sheet. They kind of knew where to find information, and they did also realize with me, now I was prompting them, like, do you like that blood pressure? What do you like? What about that heart rate? So some of it I was like pulling out of them. You'll get there. You'll definitely get there. So I don't want you to be, I can't tell you to not be nervous the first time you do anesthesia. It is nerve-wracking. But I just say, if you prep the night before, if you read about your drugs, if you review your monitoring notes, you're going to have a lot of stuff to review, and we're going to build. Like everything I'm talking about, you'll never forget this lecture, because I talk about monitoring in almost all the other lectures I'm going to talk about. So there's going to be a lot of reinforcement of these principles as we move forward in the class. Are you taking her car? Are you taking her car?
I'm actually.
I mean, it's fine if you want to take my car.
I'm just gonna be right back because I have a class.
Okay. Oh, AJ, want to say hi? Okay, so it'll be fine. We only have a few more minutes. Let me just talk about stage. Now, stage 4 is we are in overdose. Now, stage 5 would be cardiac. We don't really say stage 5 because if you're in stage 4, you're pretty much like we're way too deep, overdose, you know, cessation of respiration, circulatory collapse, and potentially in death. Now, the first thing I do, like I was just explaining with Blitz, when the heart rate started to really drop, like it dropped pretty fast, and there was a little bit of a pain response initially, and I don't know if he got vaguely stimulated because the heart came down, blood pressure was down. My first thing was I was like, I gotta get the anesthetic off. Now, well, I didn't completely, like I said, I was at 0.5%. But I turned it down pretty rapidly. The first thing I do if I suspect my patient's trouble is I turn off my anesthetic. Because the thing with the inhalants is if you're not delivering it, it will leave the brain and you'll start to dilute them with oxygen and you'll start to wake them up. Now, the very last lecture I give you guys in Anesthesia 2 is I talk about anesthetic emergencies and anesthetic problems. So I will get into some of, okay, your patient did this, what do you do? I know I'm kind of talking about it right now because I'm trying to explain the stages and planes, but that's the very last lecture before you guys go into surgeries. I give a whole like problems, what do we do? Okay. And at this point, the fastest thing is you have to get the anesthesia off. You got to get them out of anesthetic depth. We got to get them to kind of come, because when an animal wakes up, they're going to go backwards through these planes. So they're going to go from stage 4 to stage 3, stage 2, and, stage 1 is when they're recovering. Now sometimes dogs wake up really goofy from anesthesia. They go through an excitement phase. They're going through that stage 2 that I talked about when they go to sleep. Sometimes they're paddling, they're vocalizing, and we have to kind of hold them, restrain them till they kind of figure out, oh, okay, I'm in surgery. This is Kayla, she's holding me, I remember her. It kind of takes them a minute to be like, okay, now I know what I'm doing. So okay. So just to summarize, stage 3, which has the 3 planes, is normally where we are for like dentals, spay neuter, fracture repair, surgery. But if they're plane 1, it's light. That's right after you induce them and intubate them. As they get on the maintenance, which is your isoflurane, they're going to move then into a medium, or what we call surgical anesthesia. I call stage 3 plane 2 surgical anesthesia, and that's where you want to try to keep them. Now, again, sometimes they get a little deep and they're going to move to stage 3, plane 3. And this is when we turn the vaporizer back and forth. Like sometimes I'm like, let's try 125. Like that's the cat when I was leaving was at 125. Heart rate was and respiration were coming up. I'm like, you might have to go to 1.5. Well, say then all of a sudden things were dropping. She might go back to 1.2. So sometimes, I call it, you dial in anesthesia. You just keep turning the dial till you find that spot where you like all your vitals. Okay. Do you have any questions?